So we've covered a lot of ground. We've touched on this notion of guidelines and pathways. We've touched into step edits and tiers that payers use. And I want to begin with that payer story again, because one of the aspects as we think about value-based care, which has been kind of the background theme of much of the conversation, has to do with how you assign cost. And it's been pushed in the OCM to be global cost, and global cost even includes, for those participating practices, not just the cost that they're responsible for in terms of that they prescribed, but cost incurred for that patient even for non-oncologic care, and for patients who choose to go to an ER when they maybe could have gone to the office or a weekend, et cetera. So I'm curious, from a payer perspective, can you assess global cost of care? Do the costs that are incurred as a result of toxicities be attributed back to the drug? Or is it too complex to do it? Can it be done? Is it done?
So we do look at total medical expense or total cost of care. That is one of our key factors with our clinical partners. At the most fundamental level, it works with our large health systems and independent practice partners that are in total cost of care models for an attributed population. So this would be for cancer care, pulmonary, rheumatologic disease, diabetes, hypertension, all that. In cancer care, we've limited total cost of care to being for cancer care. So we're not looking to have oncology groups, in a sense, accountable for managing or co-managing, say, psoriatic arthritis. So the total cost for the cancer episode, to your point, Bruce, would include an ER visit, low acuity non-emergent ER visit, or moderate acuity ER visit that could have been avoided had the oncology group had better clinical pathways and same-day appointments, flexible appointment scheduling, just as we see in the primary care medical home, the oncology medical home, which we stood up with one large group. And as we've focused on the episode-based payment models simultaneous to the oncology medical home, and breast cancer has been the leading area of cancer. So very, Bill and Joyce, appropriate for today's discussion, that's been the area where we've done the most deep data science analytics and defining what goes into the episode and what gets excluded and what the outlier points are. So then it really becomes incumbent for like clinicians like you were when you were in practice, Bruce, or Joyce and Bill, to make decisions that are first and foremost in the best interest of the patient, but then also through the lens of total cost of care, which, as you mentioned, Bruce, includes the toxicities, the side effects, the potential need for hospitalization. I was hearing from someone today, a primary care internist like myself, about something from Canada. I'm digressing. I realized that it treats mucositis very well, that he was talking about. A friend of his, actually a physician with Joyce, with stage 4 breast cancer. So we do look to our clinical partners to make those complex clinical decisions. What we do as a payer, Bruce, is tee up information using our SAS programmers, our data scientists, to help our clinical partners, she or he, to understand where those costs reside, and then making thoughtful, as I mentioned before, Bruce, we are not in the guideline business. We have chosen not to go that route. Some payers have, and I'm not saying good, bad, or indifferent about that, but we chose not to do that, and rather working with our clinical partners to navigate and make decisions about when or when not to do PET-CT, or which supportive therapies to use in the treatment or management of cancer, what doses of the blood stimulators to use, and that sort of thing.
And in this episode design, are episodes then paid as a bundle payment?
So today they are, great question. Today they are retrospective. So it's fee for service, and the clinical partner will see where they ended up at the end of the episode that has a defined length, 6 months, 9 months. In the future state, we are in discussions with a prospective episode. So the claims that will be dropped, using an insurance term, claims submitted will be $0 paid. The claims are needed to track the utilization, the resource use, and to be able to look at that prospectively, retrospectively. But the cost will be based on a X number of dollars for that episode. So we are moving sometime this year into the prospective payment.